Hi, everyone. Good afternoon. Snehal Bhatt here at the University of New Mexico, and it's my thanks for joining for Grand Rounds today. And it's really an honor and a pleasure to introduce Dr. Larry Leeman, who's our Grand Rounds presenter today. Dr. Leeman, he's needs no introduction. He's really really an international superstar, I think, with a lot of the things that he has accomplished and continues to accomplish. Dr. Leeman MD MPH, he's a full professor in the family and community medicine and obstetrics and gynecology at the University of New Mexico School of Medicine. And he's also board certified in addiction medicine. He actually directs UNM's family medicine maternal child health program and has been the director of Milagro, providing really wraparound care, prenatal care, as well as OB care and care to the baby post-delivery in a very comprehensive and trauma-informed model, treating really individuals with substance use disorders. That's routinely been held up as a model program actually by SAMHSA. He's been the medical editor of American Academy of Family Physicians Advanced Life Support in Obstetrics, the ALSO program, since 2009. And he's really introduced the program internationally, including Mexico, Guatemala, Honduras, India, China, and Ecuador. So really important work. And I know Dr. Leeman jumped headfirst into the kind of the psychedelic therapy piece, some time back, and completed and graduated from the California Institute of Integral Studies, the CIIS program in psychedelic assisted therapies and research in 2021. He's been certified in MDMA Assisted Therapy by MAPS and also been trained in Ketamine Assisted Psychotherapy by both PRATI as well as Polaris. And he's currently completing his second year in training in Hakomi, a form of mindfulness-centered somatic psychotherapy. And he's also in the Grof Holotropic Breathwork practitioner training program. And during a research sabbatical at the University of at our institution, he actually went to the University of Wisconsin, participating in research with MDMA and psilocybin, other psychedelics. His current research focus in psychedelic assisted therapies at the University of New Mexico focuses on trauma and addiction, group psychedelic assisted therapy, as well as the use of MDMA for postpartum women with PTSD as well as opioid use disorder. So it's really great to have you, Dr. Leeman, and I'll turn things over to you.
Great, thank you, Snehal. It's great to be here with everybody. Look forward to some point in time when we'll actually be here all together. So hopefully that won't be too much long. So this is going to be a talk about MDMA, and one line that comes up a lot from the MDMA therapy, which you might think about, is why would anyone call this ecstasy? And that has to do with the fact that people are sitting there bringing up their trauma. It's not the idea of most people's ecstatic experience. So I'm going to talk about MDMA assisted psychotherapy for PTSD and addiction. It'll actually expand a little bit into talking about general psychedelics for addiction, because as we try to sort out the mechanisms by which these compounds work, some of them overlap. So no conflicts of interest. MDMA is a Schedule I drug that has no current approved therapeutic indication, nor does psilocybin. Objectives, going to talk about the role of trauma and PTSD as common root causes, go over the phase 2 and 3 studies of psychedelic assisted therapies, get into the therapy part, talk about the elements of psychedelic therapy, including set and setting and such, and describe how we think MDMA and psychedelic assisted therapies for trauma addiction may work, talk about the neurochemical and the psychological pathways. So one question you might be having, my friends have this question: why is a family physician trained in addiction medicine interested in using psychedelic compounds for trauma and addiction? So give a little bit of the background. I've been caring for pregnant and postpartum women as well as their babies for 20 years, the UNM and medical director of Milagro since 2011. Care for about 150 women a year in pregnancy, 200 babies a year at UNM neonatal opioid withdrawal syndrome. As Dr. Bhatt kindly said, I think are somewhat viewed as a model program around the country. We have wraparound care continuity model. And, prior to the pandemic, a high proportion of women in remission for opioid use disorder at time of birth. So shouldn't we just be happy about that? Well, the problem is, I've done it for long that I keep seeing the same pattern. I get through the pregnancy, so get somebody's on buprenorphine, they're on methadone, they often go 6 months, their baby makes their way into the focus program. And then I often don't see them. 2 years later, they're back, they're pregnant. They're back on using, well, it was heroin, now it's probably fentanyl. And I've seen that pattern going on and on. And so started to, give some thought, what is the deeper part of it? What's actually going on here? Am I really treating the root of their addiction, or am I just treating their cravings and their withdrawal? As I worked with these families, we see what all of us, I think, see extended families with substance use disorders. I've had families that do a genogram. I can't find somebody who doesn't have a substance use disorder. And I don't think that's all genetics, right? There's more there. So, we're all familiar now with adverse childhood experiences, post-traumatic stress disorder. And so, really that's how I transitioned into wanting to focus more of my addiction care on trauma. And really, to me, MDMA and psychedelic compounds are as a way of assisting therapy, are the most promising things there. Some things to think about too as we work out. Also worked with the Native American population. And I think it's important to realize a lot of this is ongoing trauma. It's not all post-traumatic stress disorder. I actually had a meeting with some Native elders about potentially using MDMA in those communities. And as they said to me, there's nothing post about it. We're living in colonization. That's a trauma. There's a lot of intergenerational and collective trauma in New Mexico, I think. And this is just a nice from a community group, Bold Future. They've been kind enough to let me share this. But this slide is just a remembrance that each pregnant woman, each person is an individual, not a statistic in my talk here. So links between trauma and addiction. A lot of you probably seen this book by Gabor Mate, In the Realm of the Hungry Ghost. It's more of a ethnography, almost an anthropological story where he talks about all the histories. But this quote here I think is worth introducing. Not all addictions are rooted in abuse or trauma. They believe they often be traced to painful experience, are heard at the center of all addictive behaviors. And he uses well beyond substance abuse, but to other addictions. This is a wonderful book, by the way. I recommend it to fellows and residents, anyone who really tells me they want to get into addiction care. So to transition into MDMA, what is MDMA? It's a derivative of amphetamine. It's not a classic hallucinogen. We'll talk a little bit about classic hallucinogens like psilocybin. It's a derivative of amphetamine. It has some properties of a stimulant and a psychedelic. Different words have been used. People call it entactogen and pathogen, different things to address the idea of a drug that increases self-awareness and empathy. It was synthesized a long time ago, 1912. It was actually used legally by psychotherapists from 1976 to 1985. Some of you may know Dr. George Greer, who's the former president of the New Mexico Psychiatric Association. He published the early and kind of classic research on use for couples therapy. A little shout out to Dr. Greer. So then what happened, MDMA made its way to recreational use as ecstasy or Molly, popularized at raves. And, there are a lot of things that really looked very dangerous about this drug. There were reports of deaths and seizures due to hyperpyrexia, dehydration, hypernatremia. The DEA responded by categorizing it as a Schedule I drug. Schedule I drug means a high potential of abuse and no medical indication. There are actually, interestingly, probably for the first time when a drug was scheduled, there were psychiatrists, psychotherapists that testified to try to prevent that because they were testifying they were using it as therapy. But given all the concern at the time, it was classified. You may have heard the idea that MDMA causes brain damage. So Science published an article in 2002 by Ricarte at Hopkins demonstrating brain injury in primates at doses similar to human exposure. But he accidentally used amphetamine. He wasn't MDMA. He then retracted that, and he had a series of methodologically flawed studies. So that what you may have seen, it made a lot of headlines, actually was talking about amphetamine, not MDMA. So when did MDMA start being studied for PTSD? It was first in 2010. There were 6 phase 2 studies that were then published from 2013 to 2019. These are all small, relatively small phase 2 studies. We'll talk about the phase 3 studies in progress. The pooled analysis of the 6 studies, though, when this was people with moderate to severe PTSD, were fairly dramatic. 82% clinically significant symptom improvement based on the CAPS-4 scores, dropping an average of 44%. 24 points. 56% of the participants no longer met the criteria for PTSD. And these were people that had had PTSD for a long time. In these initial studies, everybody had actually had to have gone through medications and psychotherapy. When the long-term follow-up was continued to 12 months, increased to 67% no longer meeting PTSD criteria, and 20% had continued improvement. So even well after the use of the medication-specific therapy, we continued to see improvement. And just to put it, look at it visually, you can see this is what happens by the second session, and that was the endpoint in those studies. But then when they gave some people a third experimental session, continued to improve there. I'm going to go through the details of the therapy in a little bit. So there, again, a look at a different way, proportion of subjects meeting diagnostic criteria after 2 sessions. The people that are in the control group, 77% did, but it was only 45% in the active group. That compared favorably to other trauma-based therapies using cognitive processing or prolonged exposure. And for those of us who are visual learners, you can see on this graph here, you can see that although there is a benefit to the psychotherapy, because there was no group that had no treatment. It was psychotherapy or alone, or psychotherapy plus placebo versus MDMA. So there's benefit to the psychotherapy, but much more dramatic in the MDMA assisted therapy. Some of the people were followed out as long as 4 years. You can see that the severity was continued to be decreased. Then there's a phase 3, and just to remind us all, so phase 1 studies are done really for safety. Phase 2 to get some idea of efficacy, and phase 3 are the studies that are done before a drug can actually get FDA approval. So after the very promising phase 2 studies, the FDA gave MDMA for PTSD breakthrough status, and then approved 2 studies. One of those was published in June 2021, and basically it showed the same thing. I mean, if you look here, you can see the proportion that are responders, proportion that have loss of diagnosis. It showed the same promising results as occurred with the other study. We're now in the midst of the last study. It's about halfway done and should be completed sometime this year. And just to show this here, it's not just the CAPS, which is now the CAPS-5. You can see decreasing the Sheehan disability scale. There's dramatic improvements, and also on the Beck as well. So there seem to be effects on multiple scales. So I'm going to take a little pause here from giving you statistics to actually spend about 3 minutes with a couple of patients and some therapists. Take me a second to switch the screen here. This should work.
I'm Rachel Hope. I live in West Los Angeles. I was one of the original subjects in the clinical trial in South Carolina testing MDMA Assisted Psychotherapy to treat PTSD.
My name's Tony Macy. Went to Iraq in 2006 and 2007. When I got back, I was diagnosed with PTSD.
I was diagnosed with acute complex post-traumatic stress disorder, and that's because I had many different kinds of traumatic events that collectively created a really complex and difficult one to resolve. The first 8-hour session I had with MDMA Assisted Psychotherapy, I immediately had a reduction of symptoms that was obvious.
A lot of different participants have stated over and over is this is like having 3 years of therapy in one day. And with MDMA, we're really offering a very short-term treatment that requires only taking a medicine 2 or 3 times.
Well, in our first study, people had to have had psychotherapy and medications for PTSD and not been helped adequately. And the average duration of the PTSD in that study was 19 and a half years. And most people had had lots of therapy and a number of medicines. Once they got MDMA assisted therapy, 83% of the people who had not responded to other treatments responded to MDMA versus 25% with the same therapy but without MDMA.
I remember during the therapy, one of the first things I said when it kicked in was, this is what I've been looking for. I reconnected with myself. I did a lot of internal work, and afterwards it was like a huge weight was lifted off my shoulders.
For like 20 years, I was trying to use all these other therapies. I wanted to be free. I wanted to be able to have control over myself. I didn't get any real healing until MDMA. Since the MDMA assisted therapy, even the first session, it was like 75% of all that just went away.
I went to the VA on and off, I don't know how many times, and did the therapy that they had, did the medication therapy, and then I kind of just fell off the radar and secluded and did my own thing and got really dependent on a lot of the meds.
The emphasis is on MDMA assisting psychotherapy rather than MDMA being the drug that is given automatically by itself.
We see the MDMA as a catalyst to help people have a therapeutic experience. Not just we give a drug to change the symptoms, but we give the drug to help people have an experience that then gets at the root of what underlies the symptoms.
That MDMA is really the support that then allows the participant to go fully into the expression of their trauma and their emotions in it. And that as a therapist, we're just holding that container for them to be able to go through that process.
By adding this,
Hopefully that worked, that you were able to see that video. Good, good. So I really want to make the point that they're making there at the end. Like, people talk to me about, well, does MDMA do this? Does psilocybin do that? I don't think MDMA or psilocybin really do anything exactly. I mean, I think that if they did, we'd have like 1 million people in England who go to raves every week that had no trauma. I think really it's really important to realize that in all of these methods, MDMA assisted psychotherapy, there's still a question of what is the optimal psychotherapy, but that's really the paradigm, is that we're looking at how to use MDMA, or if you talk about psilocybin, to assist therapies for transformation, not simply giving them medication. So the models and these are models of psychedelic assisted psychotherapy that, are similar to MDMA and similar to psilocybin. We'll mention a little bit, Dr. Bott's leading some studies here on psilocybin and alcohol use disorder. So preparatory psychotherapy, 2 to 4 sessions, maybe about 90 minutes, establishing trust, discuss issues of substance abuse or PTSD, prepare for the medication. Then, depending what kind of medicine is being used here, 1 to 3 sessions with MDMA or psilocybin. I'm not going to talk about ketamine, but that is a legal prescribable form of psychedelic assisted psychotherapy, which is 3 to 6 sessions. Then there's a series of integration sessions, 1 to 3 days after the psychedelic session, maybe by phone. In this age of COVID, increasingly they're being done by internet link. Psychotherapy sessions are after and between the psychedelic sessions, which transition from being the integration to preparing for the next one. 12-week total treatment in the psilocybin and alcohol studies, 12 weeks in what I'm going to talk about now, the MDMA studies. So the MDMA model is two-person therapist, usually male and female. The reason for male and female, and that's, obviously that's kind of a gender-based way of looking at it, but is that it's very common that even though we're working with issues that may relate to like a trauma that's violent, maybe war-based, it may be something that happened, a trauma that happened as an adult, a sexual abuse that happened as an adult, it is really common, in my experience doing that, of going back into childhood issues, and sometimes having like a male and a female can be helpful as far as different issues that have occurred with different parents. The therapy is non-directive. The idea is providing a safe environment, allowing the patient to kind of bring up this as sort of a Rogerian approach. You don't have to bring up the trauma; it comes up. I mean, if you basically take away people who's had significant trauma, you take away their fear. They're in a safe environment; they bring that up. There are things that are done to kind of guide them to going internally. Eye shades are commonly used. Initial dose can vary in different different studies. A common one is 120 or 125 milligrams with a booster 2 hours later. Medically, blood pressure monitoring before the first dose and the booster dose, that's the only time it needs to be monitored. There's a manual, so this is a manualized therapy, focuses on what is the therapist foundation for working. And I'll talk a little bit about the training, but it's a 100-hour training to do MDMA assisted therapy. Talks about how to support the participants process, the prep sessions, the psychotherapy, integrative, and therapist self-care. These are intense. I mean, this is like not your usual day where you go to your clinic and you see people for 50 minutes and then you get 10 minutes or something. These are sessions that last, usually with 6 hours, 6 to 8 hours. So therapist self-care is important. Most people when I've talked to that have been involved in research feel like it's a max of 2 per week is about all most therapists would want to be doing. So the therapeutic effect is really the interaction between the effects of the medicine, the therapeutic setting, and the mindsets of the participants or therapists. The MDA reduces fear by helping people stay engaged and not being overwhelmed by anxiety. As we know, when we're talking about our deepest trauma, it's often not possible for people to get into a window of tolerance. They go into anxiety and panic states. They go into freeze states. The MDMA temporarily takes that away. The role of the therapist is mostly, being an empathetic presence and listening and supporting, what's described in the MDMA manual instead of more the patient's own inner healing. A little picture here in case you're wondering what it looks like. So how does it actually work? So as far as how do we work, I would like to talk about 2 different things. How does it work neurochemically, but also how do these work psychologically? How does MDMA work, and how do any psychedelic medicines work? So as far as neurochemically, it's rather complex for MDMA. It's much more straightforward how psilocybin works, which is simply on one receptor. Here it's a release of serotonin, dopamine, noradrenaline, and oxytocin. Activates serotonin receptors, decreases anxiety, and amygdala-related fear response, and increases empathy, emotional closeness, and compassion. There's also an effect on the alpha-2 receptors by decreasing trauma-reactive hypervigilance. Sort of like a bit of a clonidine-like effect there. So it's working in those ways. The oxytocin I'll talk about a little bit because one of our studies is postpartum, and there may be some potential for that helping actually bonding with the infants. So how does that work? So the oxytocin release is hypothesized to promote empathy and closeness by reducing the activation of the amygdala, also the insula. There's less fear and anxiety. So the memories can be processed, and the memories could be what would be described as reconsolidated there. It's actually a fairly fascinating process in my experience. Actually watch how that occurs, how people because before we do any of these sessions, we've had at least 3 90-minute sessions with them and watched as the change occurs through the experimental session. So one thing you might be wondering, is this cost effective? And just to summarize, what we're talking about is about 40 hours of therapy with 2 therapists. That is a lot of therapy. So is that actually cost effective? So this is one, basically a decision sort of analysis type estimate. It did benefits projected for 30 years for a cohort of 1,000 patients using MDMA versus standard care. Has 40 deaths averted, $100 million saved. Now that is over 30 years. Now it doesn't have to go for 30 years to be better and cheaper. If you estimate that the benefits cease after 10 years, you've saved $36 million, averted 19 deaths. So this looks like that's beneficial. Now, I'm sounding like I'm painting a very rosy picture of MDMA therapy. I'm actually going to present some of the other side as well. I mean, this is being done based on highly motivated therapists that have a lot of training. And so it's not inevitable that this would actually happen the same way when you take the drug out of study and put it into practice. So another way of looking at it is comparing the rates versus SSRIs here. So as you can see here, and as we all know, there's a high dropout rate for sertraline and paroxetine. Very few people drop out of their MDMA study. So that's talking about PTSD. I mentioned that I got into being useful because I wanted to be involved in helping treat addiction. And so might MDMA be useful to treat addiction is sort of a question. We have a study here that's been approved by MAPS and is being reviewed by the FDA. And I'll go into the details of that. But when you think about being useful to treat addictions, I think there's two ways to looking at it. One is, can this occur simply by treating the PTSD? And so if we said the PTSD is a root cause, if you treat it, will that decrease the relapse rate? And the study that we're proposing here is to look at postpartum women. I mentioned they have a high relapse rate. If we treat them at that 3 to 6 month window, can we treat them in that way? But the other possibility is that maybe it works in the same mechanisms classic psychedelics, such as psilocybin, that are working on the 5-HT2A receptor. And we'll talk about what that mechanism may be, but it may be that it's not simply through PTSD. There may be a pathway through PTSD, and there may be a pathway that's more similar to the classic psychedelics in addiction. So I'm going to actually go into talking some about how the classic psychedelics work. So psilocybin and addiction. Psilocybin is the active ingredient in psilocybin-containing mushrooms, metabolizes psilocybin inside the human body. Actually, psilocin is the active the ingredient of the mushrooms, traditionally used by the Mazatecs in Mexico, Sierra Mazteca, and it stimulates again the serotonin receptors. So this is Maria Sabina Mazatec curandera. I have her picture up there for a reason. We're presenting some of this as though these are these new medicines and we found them and we know what they do, but in reality, like psilocybin, that's not true. Mescaline, that's not true. So a lot of these medicines being studied for addiction have a long indigenous history, and I think it's very important that we honor and respect that. MDMA doesn't have that. There is no plant equivalent to MDMA. So the psilocybin studies have been done for numerous things, treatment-resistant depression. That's actually what psilocybin has the FDA breakthrough status for. Depression and anxiety with cancer, that had very promising results. The studies in both NYU and Yale. Addiction, tobacco, alcohol, and opioids. And psilocybin basically is a classic psychedelic, similar effects to LSD and mescaline, but a shorter time of action, so it's easier to use in studies and for psychedelic assisted therapy. There are very promising studies that were done back in the 60s and 70s of LSD, and hopefully it'll be possible to replicate some of those. But there are a couple of problems with studying LSD. One is that it's a long span. With LSD, you're probably almost mandating that people would have to have an overnight stay, while psilocybin, people may be able to go home. Also, those three initials have a whole lot of cultural baggage that's not there with psilocybin, and so that may be one of the advantages of choosing psilocybin for research. How does it work here? It binds to the serotonin receptor. The feeling is that is how this drug works. They've done studies with ketanserin that blocks that, and it'll block the effects of psilocybin. So the effects of psilocybin seem much more straightforward than MDMA. What happens with psychedelics? How do they work? And this is a lot of hypothesis here. I would say there, but the idea is that it works on the default mode network. By working on this, it actually allows a greater amount of connectivity to be happening than before you're using the psychedelic. So it actually sort of damps down some of the things that are essential to our life plan. We could not go through life of being hunter-gatherers doing psilocybin, right? You'd be eaten by a tiger rather quickly. So we have a lot of things that help us to focus and to decrease connectivity. This changes those. So the potential effects of decreasing the activity in the default mode network, this can been shown by decreasing blood flow. You can see this on functional MRI. But what does that do psychologically? Hypothesized to decrease rumination, obsessive thoughts, and the focus on autobiographical content that are so common in severe depression, and also common in anxiety patients with terminal cancer. More awareness in the present moment. That can be looked at in a functional MRI as more connection between neural networks, and then more connection externally towards the natural environment. I don't have time to present that here, but there are actually studies showing that the psilocybin actually does increase ecological awareness. Psilocybin and tobacco cessation here, very small study that was done here, 15 participants. But as we all know how hard it is to get abstinence, these were impressive. At the 12-month follow-up, 2/3 were biologically confirmed as smoking abstinent by urinary cotinine. At 12-month follow-up, 13 related their experiences among the 5 most personally meaningful and spiritually significant experiences of their lives. So that's fairly phenomenal, right? 2/3 of people actually that are successfully quitting smoking. Is that related to this deep experience? In general, the studies that have happened with psilocybin and alcohol have shown that the intensity of the experience as measured by the mystical experience questionnaire does seem to correlate with the likelihood of success with addiction. So good news, I think it's good news. October 2021, NIDA is going to fund a 3-year multi-center study of psilocybin for tobacco use disorder at Hopkins, Alabama, NYU. This is groundbreaking. This is the first time that NIDA is actually moving forward to start funding these studies. We're hoping they'll fund us. I'm not going to talk too much about this here. This is Dr. Bott's study that he's done with Dr. Bogenschutz and is close to publication. But this is the landmark, study, and this is using motivational enhancement and psilocybin for alcohol. So I can't present the results because they're not published yet, but I think they will be very soon. So what about MDMA and substance abuse? Have there been studies on that? There's really just been the one study here, which is it's called the Mdma study from Bristol. They took 14 patients aged 18 to 65. They ran them through something very similar to what I'm describing for MDMA and PTSD, but they did not require that PTSD was an inclusion criteria. This was simply taking people with alcohol use disorder, had then undergone detoxification, and they had 2 sessions that they used MDMA, and the others were psychotherapy sessions. And I'll show you the data again. This, I would say, has a promising signal, but it's too small a study to actually really determine effectiveness. But it's enough to make us want to try to replicate this with OUD. And by studying OUD and PTSD, we're actually can look at 2 different mechanisms. So here's this is the study here. They received the 8-week course, and this is the rates of people that relapsed after they had that. Now, again, this is not a randomized trial. This is purely a very small observational study, enough to give a signal, not enough to prove efficacy. But they did compare here the Mdma study versus looking at a similar group that was treated. So it got historical control, in the same program, and again shows a promising signal. So they're planning to study this more in England. So one question that's really comes up a lot is, how can psychedelic assisted therapies treat a wide range of illness? I mean, a lot of us tend to be, I think, appropriately kind of skeptical. What is this, some kind of panacea? This treats depression, it treats anxiety from death, it treats tobacco, it treats alcohol. How can that actually work? And I think that's one of the questions that people are trying to sort out. So one of it is that there may be things that are sort of common factors in mental illness there, things that affect depression and such. I think one of those is actually this idea of rumination, that people continue in these sort of thought patterns, and something needs to break that up. Something needs to change that and kind of get them into a different state, potentially a pivotal state that'll allow them to change that. So I'm going to talk about the idea of pivotal mental states. The idea is that you'll leave a long-standing state, whether it's addiction, depression, PTSD, anxiety, or obsession, can occur from a transformative experience that produces a pivotal state. The classic psychedelics, you can produce a challenging experience, a mystical state, or other pivotal experience. I'm going to talk a little bit about the different ways we look at this, but I think, again, it's important, just as I mentioned, that why do they call it ecstasy? Most people who are going through psilocybin in the environment they're going under that, they may find it's a deep, rewarding, transformative experience, but it's often challenging, and those challenging experiences may be part of being a pivotal state for change. So here, give you an idea of a pivotal state here. So here we have a little boat which is being affected by the 5-HT2/TA receptor, and there's well and there's unwell, and it's kind of moving down the shore there. what happens, what happens with that state. So I think that that's where the idea of integration comes up. So someone has a intense experience. If that happens, in a non-therapeutic environment, sometimes it's challenging. Sometimes those are the ones that would, people describe as a bad trip. Some people would wind up in the ER. So how does it affect, like, whether this is a positive experience or a negative experience? So going all the way back to the studies in the 1960s, and we blame a lot of things on Timothy Leary as far as upsetting psychedelic research. I would give him credit; he did come up with the idea of set or setting, that the place where the person is having the experience and their mental state seem to be very important on it being a positive experience. Where they're going to wind up is not always clear, when they finish the experience there. And so really all the studies that, are being done should include a strong integrative component. I think that's important both for safety and also to increase the positive outcomes. I'm not going to go into psilocybin and depression, but I mean, there were some adverse outcomes in the people who had the psilocybin. Some people did wind up getting more depressed and suicidal. So the integration, I think, is key for all of these. The integration is helping him make his way down the river. So again, the challenging experiences are not bad, but they may leave us at that pivotal state. Most individuals with a challenging psychedelic experience eventually follow the stream to positive transformation, but we think that is based on having good preparation, good integration. A survey, and this was just a retrospective study of 2,000 people with adverse psilocybin experiences outside of a clinical trial. A third reported this was one of their most challenging life experiences, but eventually 84% reported long-term positive gains. I think it's really important to, realize this when we're talking about training therapists, learning how to do this. I think that actually training somebody to sit with somebody in a psilocybin session is not anywhere near as difficult as training people to help with the integration, which is, is a much more deeper psychotherapeutic process. So what are we proposing to do here at UNM? UNM MAP study of postpartum women with PTSD and opioid use disorder. This is an open label feasibility study. It's been approved through MAPS, and we're working with the FDA on exactly what the proposal criteria will be. But we're going to use postpartum women 3 to 6 months after birth. We're going to use women who have the opioid use disorder on buprenorphine or methadone, a diagnosis of moderate or severe PTSD based on the CAPS-5. We're basically going to use the MAPS PTSD protocol, including 3 MDMA medication sessions, preparation, integration, as well as a motivational interviewing component. The primary outcome of this study is going to be PTSD based on the CAPS-5, but what's a novel outcome is the opioid use disorder using TLFB, comparing 30 days prior to enrollment to monthly assessments for 6 months. We're going to continue urine drug screens for 6 months, so we'll get an idea, how many people are relapsing. Given that this is normally a high relapse sort of time, that's why we picked 3 to 6 months. If we waited to a year, I think most of those women that I talked about coming back would already have left our care. So that's why we're choosing 3 to 6. We're not doing this at 2 months because most women want to be focusing on their baby at that point. We're also curious about a few exploratory outcomes. One is maternal-infant bonding and attachment. It's been noted repeatedly that there's a sense of closeness that develops with MDMA therapy. We know that oxytocin is released there. So what we want to do is see whether the maternal-infant bonding and attachment can be improved. Women who've had trauma, anyone who's had trauma, have a higher incidence of issues with attachment, issues with maternal infant bonding. As we're trying to look at affecting intergenerational trauma, this is potentially one point of doing that. So again, this is exploratory outcomes, but our protocol is doing videos of the mother with the baby before starting protocol, and either the morning after or at hour 45 of the MDMA session. And then, so that would be recorded. The nice thing about doing these videos can then be reviewed by expert examiners, which will not know whether the mother is where they are in the protocol. We won't know if she's not started the protocol, finished the protocol, or had a session. And there's a couple of other bonding and competency scales that'll be used. The other issue is like, how is this changing? So let's say that we are seeing positive outcomes. How is that working? We are going to look at the mystical experience questionnaire, but based on the MDMA studies so far, this type of experience, which occurs with psilocybin, has not been associated with a positive outcome with PTSD. But no, people haven't studied addiction before where it has been shown as positive. The emotional breakthrough inventory assesses processing going on there, and the challenging experiences looks at challenging experiences encountered during the session. So these are trying to get some idea. If we are seeing a signal of a positive outcome with OUD, what are the important psychological processes? There may be some way we can support those processes. We also want to look at connection. So I've done some other work with addiction with ketamine, where we've done group work. Found actually the group work appears to have great benefit. And just to mention a quote I always like from John Harry, which is the opposite of addiction is not sobriety, it is human connection. And so one thing that's been looked at with these substances is how is that connection being affected there. So we also have exploratory outcomes that include social connectedness, identification with all humanity, and then a newer scale, the Watts Connectedness Scale, that's been developed out of the psilocybin work, that's looking at connection to self, others, or world, universe. So again, those are outcomes that we're going to look at, but since we're hypothesizing that connectedness and the lack of it is part of addiction, we want to see if these positive findings on these scales might be associated with positive findings with addiction. So these are not easy studies to do, and I think that as looking at this all in a scientific point of view, we need to maintain skepticism about this. That's what the scientific method is. We want to really see, is it truly the MDMA assisted therapy? Can there be something else that's sort of doing this? And so I want to mention about some of the issues that come up. One is the role of participant and therapist expectation. The participants invested a lot of time prior to the randomization. Can be a positive placebo effect once they find out that they had an active substance. It can also be the opposite. Imagine you really wanted to be in the MDMA study. You went through the whole study, and then, an hour later, you have a strong suspicion. You're not sure, but a strong suspicion that you didn't actually get an active compound. Well, that means you're not getting an active compound in the next 2 sessions either. So that can potentially have a negative effect. So it's important to look at the role of participant and potentially the therapist's expectation. I mean, maybe the therapist gets all jazzed when they think the person's gotten the active thing and they're kind of in there, and when they think they haven't, maybe they're not engaging in the same way. So that's an important thing to look at. Yeah, we'll skip this here. So how do you blind this? So blinding is like a key thing, right? For that's our scientific method, but it's really hard to blind an intense psychedelic experience. So in the MAP studies, about 90% can identify what group they're in. Different things are being tried, including like active controls. An active control might be giving, some Versed. It might be giving a lower dose than you'd expect to have an effect on PTSD. But this may also require a change in the research paradigm, as it's really hard to separate the compound's effects from the compound triggering an added placebo response. Nobody really has a solution to that. And so so there's some articles that came out in after the last MDMA study in Nature, and I mean, one of the things they mentioned is, well, do we really care? I mean, in other words, if there's some placebo response adding to the compound's effects, do we care about that? But that's a difficult change in our research paradigm. And the other is the therapist enthusiasm and the high level of skill. So is this scalable? I mean, right now there's been a couple hundred patients. There's a relatively small number of us that have had the ability to actually provide this sort of treatment. But now the plan is to train, assuming it's FDA approved, thousands of people doing this. Is this training actually scalable to reach enough therapists and patients? It takes a lot of therapy. Do we need to have two therapists? Would it be okay to have one therapist? Well, one of the issues that comes up, especially with MDMA, is it promotes closeness. It also, unfortunately, has promoted closeness in an inappropriate way, inappropriate touching, sexual experience. And there's a strong feeling that there needs to be additional safety in these sessions. Two therapists provides it one way. People have talked about having a video filming the whole session as being another, but those are issues that are going to come up as far as doing this in a way that's economical and scalable. So how do we train therapists here? I know that I hope there's a lot of residents out there. I know some of you are interested because some people have talked to me that want to get trained here. So what is the background needed? Right now, it's 100 hours of training with the MAPS MDMA, training, and it costs about $10,000. And so the question is how to scale that down. How do we train residents? Are they able to be one of the therapists? Can they be a third person in the room? And a lot of those are continuing to have active discussions. But if this is going to be an approved therapy, we need to be able to get our trainees trained to do that. And the training is, there may be different levels of the training. There's training for preparation, medicine, science, and integration. There's actually psychiatrists, psychotherapists, other therapists that are seeing people now for integration. The substances aren't legal, but people are using them and they're seeing them for integration. My belief is that, especially with the classic psychedelics, that integration is probably the most challenging part of it. MDMA, I think, because in MDMA, the person is involved in the medicine session. They're talking, there's therapy happening during that. So I think that requires more work. I think actually psychedelic work using depression that use psilocybin may need less training than trauma work. What forms of psychotherapy work best with MDMA or classic psychedelics? Honestly, we don't really know. I mean, people are just trying different things. Acceptance commitment therapy has been used in psilocybin and depression. MET in the psilocybin and alcohol studies, including at UNM. Mindfulness in the ketamine studies that are being done at Columbia. Patient-centered Rogerian approach MDMA for PTSD. So we don't really know. There's also psychedelic-specific training programs that are cropping up using different things that come up. Some of these will use somatic approaches, internal family systems, which is kind of looking at almost our mind as different parts that have different developmental stages, Jungian, and also non-drug experiences and non-ordinary states of consciousness. One thing to realize is that being a counselor, working a therapist, people using psychedelics, it's not the same as if you're like, let's say that you're a therapist and you're going to do, I'm going to be a Jungian therapist. I'm going to use ACT. I'm going to do that. Well, the issue is you can't really just choose the patients who want to come see that. People are going to have whatever experiences they're having. So they found that things like internal family systems seem to be important. Like people go into child states, different states. So there's probably a group of therapies that are useful. Somatic things come up where people have, pain that represents deeper things. So there's probably some other training that are needed. Questions for other research, expanding indications for MDMA, substance use disorders. There's been end-of-life care, couples counseling. Dr. Greer, I mentioned, he did couples counseling well before anyone thought about PTSD or anything. How much therapy do you need? So, I started your studies 2 or 3 sessions. Is that the right number? We're going for 3 in our study because it's a population that's PTSD and OUD. Maybe they need 4. We really don't know. And I mentioned the psychological factors. We're trying to look at that. I haven't talked too much about contraindications. Right now, there's a very strict criteria. In the other PTSD studies, you can't have substance abuse. SSRIs cannot be used and all. And so the question over time is looking at, are all of those contraindications true? And just to mention here that can MDMA save a marriage? This just came up 2 weeks ago, and I was reading the New York Times. And so again, there's a lot of potential other uses for for these drugs. So I'm gonna I have time for questions. I do need to thank a whole bunch of people. I want to thank the people for the supporting my sabbatical in the School of Medicine, support the people in Wisconsin for letting me be there working with their addiction research team. I mentioned Dr. Greer. Dr. Bott is collaborating with me on the postpartum MDMA proposal, and which is a collaboration that's been really good. I want to thank Dr. Bott and just the different places where I got trained, California Institute, psychedelic research and training and different things. Again, I want to thank the indigenous elders who shared the wisdom in the use of psychedelic assisted therapies. I think that's an important area to look at, because there are people that have been using similar substances for a whole lot longer than any of us have.
Thank you so much, Dr. Leeman. Snehal here, and
I have a
yeah,
question.
we'll open it up for questions. And please,
Yeah, I have a question. Actually, it's more of a comment. Can you hear me?
Yes, I can.
All right. Thank you so much, Dr. Leeman. I think this was a very balanced presentation, which I appreciated. I think the data is very exciting. We in psychiatry certainly need new treatments. We haven't had really new pharmacological interventions developed over the last many years. There's a need for that. And I also really appreciate that you presented the caveats of these studies very honestly. And I just want to comment, mainly for the trainees, that the placebo effect can be very important in psychiatry. I mean, we know that. And like Dr. Leeman mentioned, these studies, keeping the blind is not possible. It hasn't been possible. Yeah. I mean, for the students, you need to remember that, for example, in schizophrenia, which is my field, yeah, in the 70s, there was a huge uproar that hemodialysis was a cure for schizophrenia. And it really took off, yeah? And it really was necessary to implement placebo-controlled studies, which, as you can imagine, were very hard to do for hemodialysis in schizophrenia. So, but eventually, I mean, those studies demonstrated that although the effect on the open label study for hemodialysis appeared to be huge in these initial studies, it was all placebo effect. So it's important to keep that historical background in mind, not to minimize the importance of this data. I think the data speaks for itself. And like I said, Dr. Leeman has been very upfront about its caveats. So thank you, Dr. Leeman.
Thank you, Dr. Bustillo, for bringing up that point. I did not know the history of schizophrenia and that drug, so I appreciate that addition.
what else? Feel free to chat in or speak up. I can't see everyone. I think we have even now 70 participants. So just, no need to raise a hand. Please just speak up.
Well, if you don't speak up, I'll have to say something more. You've heard me for 55 minutes already, but I would just like to just talk a little more personally while you guys are thinking up another question or two. I found the work of working with MDMA, a very personally deeply rewarding experience, like watching people go through their trauma and watch people go through trauma that started at the index and went back into their childhood. So just to describe what it's like, it is also fairly exhausting though, to actually do this. And so I think that one thing I haven't talked about is how will this be integrated, into practice. A lot of that's going to depend what the FDA requires as a REMS, but I think that we may find that there will be specialized clinics. We may also find that people who are interested may do a day a week or something. I don't think there's going to be general therapists, psychiatrists who are going to be, doing like MDMA sessions 5 days a week. I think you would emotionally collapse because you'd be processing deep trauma every day of your life.
Snehal here, great presentation, Dr. Leeman. I, just wanted to bring up, I think the one thing that, I'll add or bring up is that, doing psilocybin work, I still think that the medication administration sessions are the biggest learning curve or challenge. for me as a psychiatrist, as opposed to an integration session where I can bring in a lot of the things that we've learned, and many of the psychiatrists and our trainees can relate to this, and you can apply those. But rarely in our training do we get the experience of being truly present, right, and holding that space or that in that safety container for 6 to 8 hours. Where you're not being overly, although in psilocybin sessions, we're not actually doing any processing the way we do in MDMA sessions, but just that experience of being present for 6 to 8 hours, for me personally, was the biggest learning curve, of the process. So I just thought I would just share that.
Yeah, no, for sure. I don't want to minimize that part of it. I guess I'm trying to like upregulate a little bit the integration part, that people realize how important that is. I would share one thing if people are interested in doing this therapy. There's something called holotropic breathwork that was invented by Dr. Stanislav Grof, who actually was one of the founders of LSD psychotherapy when the research couldn't be done. It's a way of actually using breath and music to produce a non-ordinary state of consciousness over 3 or 4 hours. That's actually a good experience. I actually did that. I went to some sessions, and it was useful for two things. One is most of us are not used to sitting down for 3 hours in a row while somebody's having an experience, but people actually do have like intense experiences. They're similar, I think, to psilocybin. So that is one way to get some training in that part of it.
I had a quick question. This is something that I talk with my patients a lot, and I love that the first time I hear IFS from a talk is with you, Larry. So thank you so much for sharing this. Most of my patients, I think, experience chronic and complex trauma. Like PTSD is not, like, that's not the problem. It's like just ongoing. And I think the somatic piece and the psychedelic piece really is kind of going to be the future of how we work with our own traumatic memories, because it's just they're not stored in the same way that other memories are. And so I'm super excited that this is continuing to be talked about and discussed. And I'm super also excited to know, like, when can we start referring patients? When is that? Like, does anyone have ideas about like how fast I can get patients in? Please. Thank you.
Yeah, well, yeah, that's a great question. I do think that somatic work is really important, and Molly, I'd be delighted to talk to you about that, off rounds a little bit, and give you some more about that. Timing: MDMA is expected to be submitted to the FDA for approval in 2023, unless there's some reason that why the next phase 3 study gets different outcomes than the last one. It probably will be approved. It's been a breakthrough, and then probably late 2023 or maybe 2024, it'll be released with a REMS, and we just don't know what that REMS is going to be. The REMS is going to, likely prescribe the training that's needed, but maybe 2024 for that. Before that, it's just going to be research studies. So we have the one that we're working through with the FDA for MDMA. Dr. Bott, do you want to answer about the psilocybin and alcohol?
Yes, very quickly. Yeah, so psilocybin alcohol, we've submitted now our results for the phase 2 RCT that we completed with NYU. And the next step is we're planning, and FDA is working very closely with it, a larger sort of a study, with a slightly different design, but with 10 institutions around the country, and we will be one of them. And our hope is to get that rolling in the next year, if all the regulatory stuff goes forward. So I think we're a few years behind with psilocybin in terms of where the data is, and we'll see where it goes. Right now, our results are looking very promising.
I do want to mention, Dr. McLean, what you brought up about, patients bringing this up a lot. I mean, one source of concern is that, people are reading the headlines, they're very depressed, and they read that, psilocybin helps, so they try to go out in Central and buy some mushrooms and go off by themselves somewhere. That's kind of scary. I mean, without people having any sort of support there. I would say, and it's difficult because we were talking about an illegal substance, so there's a limited to what we can offer. But in many communities, there are people people that are willing to do integration work, for people if they've done that. I think trying to get hooked up with someone who's willing to do that. The other thing, and this may be a source in some communities, is that ketamine assisted therapy has an overlap with some of this work. Ketamine is legal, so some of the people offering ketamine assisted therapy may be able to help them if they're having those experiences, but none of us can recommend anyone have those illegal experiences. I'm just saying if they're going to do that, to try to get that. Ketamine is a whole other thing. I'd love to give some other talk on ketamine, but Dr. Bod and I are both interested in that as well. But ketamine is being used in a lot of IV infusion clinics where there is no therapy involved. That probably works okay for depression, but it probably doesn't work as well for a lot of the other conditions. And even for depression, it may turn out that by doing it with therapy that you have more long-acting results.
And I know we're at time, but so I don't know, but there are a couple of questions still. Rachel Rose, one of our trainees, asked, what about adverse reactions during MDMA sessions? Were those seen? And what medications are available bedside? And lastly, Edward Neidhart asks, can you comment on microdosing? So two, and then we can...
Yeah, I can answer those pretty quickly. So the adverse reactions, very minimal. There's maybe one where there's one, I think, during an MDMA study where someone did have an arrhythmia. It spontaneously resolved. There's been some reactions with blood pressure, no serious reactions during the sessions. The medications that we have available would be a blood pressure medication, could be oral clonidine is a common choice there, and then nausea is also possible, and so Zofran would be the other medications. There's not any situations that have occurred in any of the studies where people had acute psychiatric reactions requiring administration of antipsychotics or benzodiazepines. And given the model here, which is that we're trying to promote a challenging experience, the idea would be very much not to shorten the experience with those type of medications. Microdosing, there's no good studies. I mean, really, the studies that are out there for microdosing suggest that it works really quite well, and that placebo works really quite well, and there's no evidence that it works any better than placebo. That's the studies that are out there, but they're not very good studies. It's been a hard thing to research. I think they are doing some studies in England. There's lots of anecdotes, but again, there you have obviously no blinding, and you have lots of positive placebo effects. So that's my take on the microdosing, that there's not evidence to really support it yet. Well, thank you so much for inviting me. It's really been a pleasure to come here and to talk about this. And as we hopefully will be able to come back, in a year or two and have some results from some of our studies and get things going. And I look forward to that.
Thank you, Dr. Leeman, for presenting, and thanks everyone. Take care.